so I just want to welcome everyone. Fantastic to have you along to this session. We've had a great plenary to kick off, and so we're looking forward to some really excellent presentations and discussion this morning. I think it's great that we've got a session on engaging stakeholders, and obviously a lot of that's consumer engagement, but other stakeholders. So I'm hoping we get a lot of engagement ourselves within this session. So please, as I said, as the presentations happen, write down your questions within the chat, and we'll get to them at the end of each session. But it'll be a great session, and hope you can really get active and participate. The session starts off by a presentation from Anneliese Synnot. So welcome, Annie. Annie's completing her PhD at La Trobe Uni and is a research fellow at Monash University. She's done a lot of research in consumer and stakeholder engagement in evidence synthesis, guidelines and living evidence, and is a long-term contributor to the Cochrane Consumer and Communication Group. So welcome, Annie. Please come and join us and start your presentation.
Thanks, Kelvin. Let's hope I can manage the tech a bit better than my last presentation. Hi, everyone. So I'm going to talk to you about how to broaden diversity and deepen consumer engagement in guidelines. And just flagging, I have no conflicts to declare for this presentation. So a little bit of background regarding consumers and guidelines. I'm sure that many of you would be aware that most guideline bodies internationally encourage or even mandate the involvement of consumers in guideline development. There's not a lot of research about how frequently this happens, but the limited amount that there is suggests it may only be up to 50% of guidelines are developed internationally with consumers. So it's definitely not a universal practice. And when consumers are included, we also know that people from diverse backgrounds are rarely amongst them. So the usual practice is to involve a few consumers, quite often just one or two, on the guideline development group. So they have a say throughout the guideline development, but the experiences can be mixed for both consumers and guideline developers. And obviously with only 1 to 2 consumers, it limits who can have a say in developing the guidelines. And there are many other ways that guideline developers have used and do use to involve consumers, but they're not widespread. And finally, there's insufficient guidance for guideline developers about how to do this. So both the practical guidance documents and the descriptive studies that do exist have been reviewed in systematic reviews and found to lack sufficient detail. So we set about to identify principles and approaches to both broaden the diversity of consumers in guidelines and to deepen consumer engagement in guidelines. So there's just a few terms there that I'll need to explain. So consumers is probably fairly self-explanatory. We're talking both individuals and organisations, and people with lived experience and also representatives. I like this definition of engagement. Obviously, involvement is another term that is used in Australia, and sometimes participation in the guideline context. But I like the fact that this talks about it being a relationship between consumers and guideline developers, and it has some impact on the guideline, and it can be in any stage of guideline development. Diversity, so we're talking about people who might experience health disadvantage. Sorry, I've blocked it with a Zoom pop-up, for social or economic reasons. And we use the Progress Plus acronym, which lists out a range of these factors. So things like cultural background, disability, place of residence. And this concept of deeper engagement, we were interested in really kind of more substantial engagement, more meaningful engagement, where people were involved in ways outside of the guideline development group or had some quite significant level of power in the guideline. Oh yes, done. So the way we set about answering this question was in a scoping review that turned into 2 reviews. So very similar inclusion criteria. One focused on broaden diversity. One focused on how to deepen engagement. And just noting that we included much more than just studies, published studies. So we included guidance documents and other kind of reports. So we found 10 documents that looked at diversity, 24 looked at deepening, and we supplemented the diversity review with 4 interviews with consumers and guideline developers, and then merged those together. And for each of the reviews, we did a descriptive synthesis and came up with a range of themes. So the documents we found came very much from high-income countries. There was quite a range of sort of types of documents, or the objective that those documents had. So there were a bunch of documents that were describing and sometimes evaluating an engagement activity that had been implemented in practice. Another group that provided practical guidance, and so they could be based on some kind of literature review or just the experiences of the authors, and some primary research that was exploring consumers and or guideline developers' views on the topic. So a real mix of methods that people used, and really nice to see an almost 50-50 split in terms of presenting the views of both guideline developers and consumers. And you can see with regards to the diversity question in particular, that most commonly we found documents looking at disability, race, culture, ethnicity and health, race, culture, ethnicity, I'll just stop, and place of residence. So just for the purposes of this presentation, I've pulled the themes together because there were a number of themes that were common to both reviews. So you can see in the middle there, things like respectful partnerships, tailored recruitment and screening, really well supporting consumers, making sure that the guideline personnel have skills and they have support. So these are things that are fairly common across the consumer engagement literature in terms of, much more broadly engaging in health, engaging in research, not just in guidelines. But what we found were very specific examples of how that might apply to the guideline context. So a lot of detail under each of these themes in really sort of practical information or practical guidance. And you can see with the diversity review, we found some additional themes there. And the deepening review too, particularly we captured impacts in that one. So impacts on the guideline and impacts on consumers. So with the time available, I have just summarised some key takeaways from what we found. So the first thing is that good practice in consumer engagement more broadly very much applies in either boosting diversity or deepening, but it may need some greater attention on particular areas. So things like building formal and respectful partnerships, particularly with organisations right at the outset before any engagement has even been planned, is important. And rather than thinking of a blanket approach where you involve people in one particular way across the whole guideline, that guideline developers critically reflect on who they want to engage, at what stage of the guideline, and with what kind of methods that might be most appropriate, and that the methods should be inclusive. So things like offering flexible ways to participate, or maybe offering multiple different methods. So it might be a survey at the start and focus groups at the end, so it catches people who want to participate in different ways. We've found quite a range of different methods that have been used or are recommended to be used in consumer engagement. And it was interesting that when those were reflected upon, or when they did some kind of formal evaluation, across the board there, it was fairly consistent that they can all be feasible, they can all be beneficial to the guideline, and they can all be meaningful for consumers. So rather than saying, this approach is right for the priority setting stage or developing recommendations, it's about tailoring the methods to the context of the guideline. So things like if it's a very contentious topic, or it's a rare condition, or there's not much evidence, and also thinking about the needs and the preferences of everyone involved, so consumers and guideline developers. And particularly when it comes to guideline personnel, this is very kind of much recognised in the literature that the guideline personnel are really key, particularly the chair, in if it's a guideline development group engagement in making sure that consumers have a good experience and can really actively contribute. But particularly for people from diverse backgrounds, the guideline personnel need to be very supportive of consumer engagement, have direct expertise in working with these groups of people, and doesn't happen very often, but they do also need support in how to engage consumers. And there's also a role for guideline organisations and funders to create a supportive environment. Things like organisational policies that mandate or encourage engagement, and things like giving more time and funding. So that's it for me. I'm not sure why it's not moving, but there we go. Just wanted to acknowledge my PhD supervisors and everyone who's been involved in my funding.
Fabulous talk. Thank you, Annie. Please, again, just a reminder to write your questions in the chat functionality, or if you do, we're happy to take questions, spontaneous questions, if you want to raise your hand. I think most of us on Zoom know how to do that. So there's a question from Melissa. What extent did you find consumers are involved in developing protocols for systematic reviews?
Well, we didn't. So, I mean, consumers were not commonly involved in the evidence synthesis stage of developing guidelines. And so to find examples of them being involved in the protocols for systematic reviews within guidelines, I don't, off the top of my head, think we found any examples. What I do know more broadly is that systematic reviews themselves often don't consider the Progress Plus factors, often termed as health equity factors. So I would say from that knowledge too, it would be very rare.
Okay, great. Emily's asked a question about whether you, as having summarised this in great detail, think that there's an ideal example, or is it really, as you said, need to be tailored to each sort of guideline or situation?
Yeah, I do. I think it does need to be tailored. I think there's kind of principles or good practice points that apply, and I think what would be really helpful is a sort of a systematic way of helping guideline developers step through those points to say, what are the key questions you need to know and ask yourself, and then, okay, so here's some of the options, and this is the factors to consider. These are the pros and cons of the different approaches. So that's the kind of information we were able to glean with some holes. I mean, it's not we didn't get a complete picture. So I suppose in terms of an ideal approach, I would say you would want to have people on the guideline development group and on any other kind of governance committees above that. So you've got that kind of multi-level engagement, and then having some engagement at key points. So I don't think that aside from the guideline development group involvement, which is obviously right throughout, but in terms of additional activities that you might do, so for example, holding several seminars or workshops at the priority setting stage, or collecting people's views on the draft recommendations at a Delphi survey later on. I don't think that has to be in every stage. I think that that's when you think really carefully about what kind of input you want. So it's the what kind of input you want and the context that you have that informs your methods. So yeah, that would be my answer to that.
Excellent. And just a really quick question from me, because I don't, and forgive me, Annie, if I already asked you this. Did you actually find a change in over time with this literature? It's not something that I don't think we set out to analyse, but
no,
anecdotally, you think that there's an increased awareness of this. Did you? Is that?
Yeah, definitely. It was quite interesting having looked at other contexts. So things like primary research and looking at consumer engagement literature there. I think that the guidelines community perhaps is less advanced in its thinking about consumer engagement. So I didn't find a great deal of examples where, the reporting is very much, this is what we did and we think it worked well, whereas some of the later stuff is really getting into the more of the principles of, mitigating power imbalances, a much deeper kind of reflection on who to involve and how, and also the methods are expanding. Yeah.
Well, thank you so much. I think that's a great introduction to this session. So appreciate your time.
Thanks, Kelvin.
Our next speaker is Aili Longford. She's a registered pharmacist and PhD candidate at the University of Sydney, and she's actually going to give us an example.
Is it just me or have we lost Kelvin?
It's frozen for me as well.
Okay, that's fine. Kelvin will come back. I will just step in and introduce Aili. Aili, I'm actually just going to ask you to take it away.
Excellent. Can you see my slides all okay?
Perfect.
Excellent. So as Kevin and Samantha pointed out, my name's Aili. I'm a PhD candidate in the School of Pharmacy at the University of Sydney. And my research team and I are developing evidence-based opioid deprescribing guidelines. Today, I want process of stakeholder engagement throughout the development process and some of the lessons that we've learnt along the way. So deprescribing is the process of medication withdrawal supervised by a healthcare professional with the goal of improving outcomes. And I suppose that deprescribing is part of a good prescribing continuum because if you're regularly assessing the benefits and harms of medicines and the harms of ongoing treatment outweigh the benefits, then deprescribing may be warranted. And in the case of opioids, there are established harms with long-term opioid use, such as increased risk of adverse events such as falls, respiratory depression, and dependence. And further, there's a lack of ongoing benefit for opioids in chronic pain conditions. So opioid deprescribing has been identified as one potential mechanism to promote judicious opioid use, but there is a lack of evidence-based guidance on when and how to do that in clinical practice. So at present, there are 5 existing deprescribing guidelines, and these differ slightly from traditional clinical practice guidelines because they focus on a specific class of medicines, whereas usually clinical practice guidelines may focus on a disease state or a condition. And each of these deprescribing guidelines have followed the processes of developing class-specific deprescribing guidelines, as outlined by the Bruyere Institute in Canada. And 4 of these guidelines have been produced by this group, and the 5th one has been led by Emily Reeve, who I think is here today from Australia, in collaboration with the Canadian group. So we followed these general steps of guideline development in accordance with the process of developing deprescribing guidelines. And I'm sure many of the steps seem familiar to you all because they probably reflect any type of guideline development process. But today I wanted to highlight some of the key areas where we engage stakeholders and our findings. So the 3 areas I wanted to highlight today was first of all our interviews with key stakeholders, secondly our guideline development team composition, and thirdly our planning for public consultation. So to begin with our guideline development process, we started by conducting 2 stakeholder perspective research studies. The first was with healthcare professionals, and the full paper of that is in BMJ Quality and Safety. And then secondly, we conducted a study with people taking opioids or opioid consumers. And these two qualitative studies were incredibly useful in helping us to identify the barriers and facilitators to opioid deprescribing in practice. But they also helped us to actually define the target population, the scope and the content of our guidelines. So I've just got this image here to sort of try and explain how some of our qualitative work directly informed the guideline development processes. So this first one here regarding characteristics, one of our participant quotes says, "I think the good thing about community is the patient is exposed to all their usual triggers. In hospital, you don't have that sort of unreal environment." So this quote is speaking to the target setting and the target audience of the guidelines. And we were able to ascertain from our research that primary care was probably the ideal setting for the implementation of our guidelines. And as such, our target audience was primary care physicians or general practitioners. And similarly, our research suggested for target populations that persons with chronic non-cancer pain may be the focus population of our guidelines. However, there was also a lot of feedback due to the transitions from acute pain to chronic pain that perhaps we shouldn't narrow the scope to just this population, but quite broadly individuals with pain. Similarly, this quote for the content section says, "It might be impossible, but I think it's important it's not a one-size-fits-all approach." So this highlighted to us the need to have some sort of flexibility within our recommendations and thinking about how we're going to structure our guidelines to ensure that they could be applied to the individual needs and preferences for the populations for which the recommendations were applying. And I think this came quite clearly through our research that opioid consumers are not a homogenous population, and so this sort of flexibility would be required. And the final quote here I have is, "I don't think a guideline on its own will fix this problem. You need to think about how to get people to actually use the guideline." And I was probably a little bit naive at the beginning of this process, thinking that dissemination and implementation would be something I'd be considering at the end of the development process. But I think our stakeholders really highlighted to me the importance of creating a guideline that is implementable and considering implementation and dissemination quite early in the development process. So I suppose the main lesson learnt from engaging stakeholders and eliciting their perspectives at this early stage is that stakeholder perspective research may actually be a valuable initial step in guideline development because I think it can actually help determine the scope and content of the guidelines. And further, it may assist in determining the composition of the guideline team. So for us, this might mean having a focus on GPs on our guideline group rather than, say, predominantly hospital physicians. And this often may not be captured if the guideline team assembly is the first step of guideline development. So for our guideline group, we had a mix of consumers, healthcare professionals, including GPs, pain and addiction medicine specialists, pharmacists, nurses, and physiotherapists. But we also wanted to engage stakeholders who may be able to assist with dissemination and implementation. So we recruited organisational representatives from groups such as NPS Medicine Wise, which is a national independent organisation which aims to improve the quality use of medicines in Australia. And similarly, we recruited implementation experts who'd had previous expertise with implementing guidelines or involvement in knowledge mobilisation tools for health-related topics. It was incredibly important to have this diversity when it actually came to developing our recommendations. And on the screen here, I've just got sort of a flow diagram of how we went from our guideline questions, combined that with our evidence and our stakeholder studies, and then used the grade evidence to decision framework to structure, I suppose, our analysis of different factors which may influence recommendations. And if I can take one example that I think was really pertinent for us, our overview of systematic reviews suggested that multidisciplinary pain clinics had the greatest evidence for opioid reduction. But when we discussed these types of interventions in our guideline development group meetings, stakeholders expressed concerns about the feasibility and the acceptability of these recommendations because there's substantial accessibility and cost and resource-related barriers to implementing these in clinical practice. So I suppose our engagement with our stakeholders at this point of evidence to decision directly impacted the strength and direction of our recommendations, sometimes where we had to downgrade a recommendation to a conditional recommendation due to these additional factors identified by our stakeholders. And the third sort of area I wanted to talk about was our planning for public consultation. We worked quite closely with the National Health and Medical Research Council throughout guideline development to ensure that our guidelines met their criteria for approval. And as I mentioned, we also worked with organisations such as NPS, and we're looking at developing some consumer resources to support our guidelines. But we also worked with the TGA Opioid Regulatory Communications Committee quite closely and met with them to discuss which organisations have a potential interest in the topic of opioid deprescribing and who would want to comment on our guidelines when we release them for public consultation. I think the lesson that we learnt here is that if you can engage with additional opportunities to understand the needs of end users, perhaps you can create additional strategies to support them, which may enhance the implementability of the guideline. So the example for us was working with the TGA. They wanted to develop an information sheet for clinicians on opioid tapering, and they wanted to do this in quite a rapid fashion to provide advice to healthcare professionals on opioid tapering. And we were able to contribute through the development of a communication or conversation guide for clinicians. And this was something that came out from our original stakeholder perspective research, that both clinicians and consumers may have difficulty in raising the topic of opioid deprescribing due to a range of reasons, such as potential disruptions to the therapeutic relationship, the stigma related to opioid use, or fears about clinicians terminating therapy without providing adequate analgesic options. So I suppose working with an additional stakeholder, the TGA in this instance, gave us an additional opportunity to identify additional resources that we could use and develop, or in this instance, adapt to create implementation aids for our guidelines. So in terms of next steps for us, we're planning on releasing our guidelines for public consultation in the next month or two. The finalist version is going to be sent through to our guideline development group this week. And then after that, we have a plan to conduct some usability testing with end users to enable effective guideline implementation in practice. So see what they believe is acceptable and useful. And we really want, I suppose, this document to be effectively used to achieve the intended outcomes. So I'd just like to thank my 3 PhD supervisors from the University of Sydney, as well as all of our guideline group members who've contributed so much to this project. And I should also just declare that I have an Australian Government Research Training Program scholarship for conducting my PhD. Thank you.
Well done. Thank you. Fabulous example, I think, really lovely example of the rigors of mapping and drawing out various stakeholder views. It's a challenging area, absolutely. So yeah, well done. Any questions? I can't see any in the chat, but anyone got a question that they'd like to? Yeah, Sam.
Good question. Thanks, Aili. I agree. That was a really neat description of how you can engage different stakeholders at different times throughout the guideline development process. I had 2 questions. My first was your stakeholder, your initial interviews and your scoping. Who were your stakeholders that you had included at that stage?
Initially, I guess we stratified into 2 larger groups, the healthcare professionals and people taking opioids. But within that, I suppose the healthcare professionals, we had a range of different stakeholders within that group. So as I mentioned, general practitioners. The initial focus groups that were conducted were at an Australian Deprescribing Network symposium. So I suppose that was reflective of people who probably had an interest or expertise in deprescribing to begin with. And then we tried to supplement that data with individual interviews with a range of different healthcare professionals, so pain and addiction medicine specialists, GPs, pharmacists, to support and I suppose maybe flesh out some differing perspectives than that initial cohort that we did the focus groups with. And then in terms of the consumers, I suppose we tried to purposefully sample a range of different types of consumers, so people who are taking opioids for chronic pain, acute pain, who potentially had experiences deprescribing or reducing opioids in the past, or people who'd had quite challenging experiences, just to sort of get that diversity in perspectives. And I think maybe that speaks to a little bit what Anneliese was talking about before, that although you have members on your guideline group, they're not necessarily reflective of the range of experiences that consumers live with. So I think that's initial step was really important to see the variance in different lived experiences and subsequent perspectives.
Fantastic. I had another question, but I don't. Maybe I can save that for later.
Yeah, happy for you to put it in the chat and follow up. That'd be great. Thank you, Aili.
Kelvin, I'm hoping you can see my screen. Okay, getting some nods. Great.
Yep, perfect.
Hi everyone. So my name is Courtney Barnes and I'm a research intern with Cochrane Public Health. And today I'll be presenting the findings from our prioritisation process to identify topics for future Cochrane Public Health reviews. Before I begin though, I'd just like to acknowledge the traditional owners of the land that I'm presenting from today and pay my respects to elders past, present and future. The potential benefits of systematic reviews may be maximised when they address priority public health issues. Historically though, the selection of research questions for Cochrane reviews has been driven by author teams based on their individual areas of interest or their capacity. Such an approach has the potential to lead to a disconnect between the reviews undertaken and the topics of importance to policy and health decision makers. So to address this risk and to minimize and to help ensure Cochrane reviews meet the needs of end users, Cochrane has developed guidance on the prioritisation of systematic review topics, which includes recommended processes for undertaking priority setting exercises. In line with this Cochrane guidance, CPH undertook a review prioritisation process to identify relevant stakeholders of CPH, determine the priority review topics of our identified stakeholders, collate and assess stakeholder nominated review topics in terms of the relevance to our CPH scope, the need and potential impact, and determine a list of key review topics for CPH for the next 5-year period, so 2021 to 2025. So just for some context, CPH publishes systematic reviews of the effects of public health interventions which address non-communicable health risk behaviours or the structural and social determinants of health, interventions operating at a population level, interventions in settings outside of healthcare, and strategies to improve the translation of public health interventions into policy and practice. So a stakeholder analysis was conducted to identify CPH stakeholder organisations working in public health policy or practice. So these included the potential funders of the reviews, policy and guideline developers, organisations working in low and middle income countries, or public health organisations with regional or global reach. Stakeholder organisations were initially identified through our CPH existing networks and targeted web searches of key organisations and agencies. From this, a list of 87 current and potential stakeholders of CPH was developed. So from December 2019 until April 2020, a survey of CPH stakeholders was conducted. Multiple strategies were used to promote the survey and encourage completion. The review prioritisation survey asked participants to identify up to 10 priority systematic review topics addressing the effects of one or more interventions. For each priority topic or problem, participants were asked to consider population groups, interventions, and settings of interest. Participants were also asked if they were aware of any existing reviews on their suggested topic, and if so, why the existing review did not meet their needs. And they were also asked if there was a deadline or reason for a review on a suggested topic, such as a planned guideline update. The suggested review topics were then assessed against the following criteria. Relevance, so did the topics fall within our CPH scope? The need, so was the suggested review topic already addressed by an existing published review? And if so, was the review that was published recent enough to be considered as current? And the potential global impact. So was the topic relevant to the top 20 non-communicable disease risk factors? Or was the topic relevant to the current 10 World Health Organization, NCD, Global Monitoring Framework risk factor indicators? Based on the assessment of the proposed topics against these criteria, a list of the priority review topics for CPH was created based on those topics that satisfied each of the 3 criteria. So a total of 36 surveys were completed, and the majority of surveys were completed by stakeholders located within high-income countries. The 36 survey participants suggested 69 review topics in total that were grouped into 13 topic areas. These topics were assessed against the previously mentioned criteria, with 6 removed based on relevance, 0 based on need, and 4 removed based on potential global impact. Non-communicable disease prevention was identified as the broad priority area for CPH for the 2021 to 2025 period. Specifically, first order priorities were dietary risks, including the effectiveness of policy, regulation, and taxation interventions on food production and supply. Obesity, including the effectiveness of interventions in health settings and at a policy level in reducing population rates of obesity. And physical activity, including the effectiveness of interventions at the policy level and those that involve urban planning and public transport strategies. The following topics were identified as second order priorities based on need and relevance. Health inequities, including the effectiveness of social policy on improving social determinants of health and public health outcomes. Mental health, including the effectiveness of interventions to encourage social connection and reduce loneliness on public health outcomes. Environmental hazards, including the effectiveness of regulatory interventions in reducing risk of domestic hazards. And knowledge translation, including the effectiveness of strategies to improve the translation of public health interventions into policy and practice, including for benefit of vulnerable groups. So based on these findings, Cochrane Public Health is calling for experienced author teams to develop review questions on these topics and submit proposals for consideration to our editorial team. Just to wrap up, I'd like to acknowledge the NHMRC who provide funding support to Cochrane Public Health. We'd like to thank our stakeholders for participating in the prioritisation survey, as well as my co-authors for the prioritisation process. Thank you.
Fabulous. Thank you very much.
Kelvin, I'm not sure if your internet is being funny again, but there's a question in the chat, so I might just start reading
Please.
it. There's a question, Courtney, from Emily. It says, can you talk a little more about the types of stakeholders you heard from in the survey?
Thanks, Emily, for the question. So we heard predominantly from other public health organisations and agencies. So as you can see from the survey results, we did have a lot more representation from the United Kingdom and Australia. And that was something we battled with to get the representation from other countries and making sure we had low and middle income representation. So we were lucky enough to have a response from the World Health Organization. So we did have an international agency, but the majority of the responses were from a national level. So for example, the Department of Health within Australia and other state-related agencies within Australia as well.
Fabulous. Was there much follow-up question was there much consistency across the various stakeholders?
Yeah, so there was definitely consistency, I suppose, with those broad topic areas that I mentioned. So we managed to collapse a lot of the survey responses into those 13 topic areas. As there was consistency in those broad areas, but I suppose we struggled with getting really specific. So we asked the stakeholders to give us essentially a PICO. So we were after a really specific research question, but we struggled to actually obtain a lot of that. We mainly got those really broad responses. So there was consistency definitely in those broad topic areas.
Excellent. Thank you so much for your presentation. And again, massive piece of work and really important, obviously, area. So thanks for presenting on what you've been doing.
Right.
The next presentation's from Danielle Pollock, excuse me, who's a research fellow from the Evidence-Based Healthcare Review team at JBI. Internet's playing up.
Thank you so much, Kelvin. I'm assuming everything is working. Awesome. First, I'd like to acknowledge the land that we meet on today, or the land I'm meeting on today, is traditional lands of the Kaurna people, and do pay respects to their spiritual relationship with their country, and also acknowledge that the Kaurna people are the custodians of the Adelaide region, and their cultural and heritage beliefs are still as important to the living Kaurna people today. And I also pay respects to the cultural authority of all Aboriginal people attending today. So just some disclosures, I am a research fellow in the Evidence-Based Healthcare Research Division at JBI. I'm also part of the JBI Evidence Scoping Review Methodology Group, the network, and I help develop the workshop, but I don't have any direct or indirect financial interests. I've also put my Twitter there. I am an avid tweeter, so please feel free to reach out through Twitter or through email. So today I'm going to be talking about stakeholder engagement in scoping reviews and the need to move from a consultation to a co-creation approach. Now, this whole session, we have undeniably seen the absolute benefits of stakeholder engagement in evidence synthesis and in guideline development, and we're seeing an increasing importance of this within the field of evidence synthesis. We see benefits such as less research waste and ensuring that the evidence synthesis is relevant to the community, but there's also challenges attached that it could potentially increase time to completion as well. Now, reason why I'm focusing on specifically stakeholders in scoping reviews is that stakeholder engagement has traditionally been focused on in systematic reviews, and there's not been a lot of evidence specifically to help with scoping reviews. And stakeholder engagement in scoping reviews is often limited or even admitted in the conduct of scoping reviews. None of the guidance that is out there has presented any clear steps on how to really conduct what they have called consultation and what the level of involvement of stakeholders should actually be in scoping reviews. We also acknowledge that scoping reviews aren't traditionally looking at feasibility, appropriateness, meaningfulness, or the experience. So traditional stakeholders of those that have had a lived experience of that particular diagnosis or health issue may not actually be relevant as a stakeholder in a scoping review. We may actually see more researchers, librarians, because in scoping reviews, we're asking questions about concepts, characteristics, we're providing a map of the research itself. So we believe that we need to move from this consultation, which isn't very well described, and potentially could lead to more of a tokenistic engagement, to a co-creation approach with stakeholders themselves. So we've suggested that there are 4 phases to stakeholder engagement in scoping reviews, and that involves pre-planning, protocol development, scoping reviews, and even after the scoping review, that engagement doesn't necessarily end there. And where JBI guidance is in this protocol development and scoping review stage that we're specifically breaking down. So in the pre-planning stage, I think it's always important for us to actually reflect on why do you want to engage with stakeholders in your review? And then how do you actually identify appropriate stakeholders? How do you recruit for those stakeholders? And how do you develop those relationships with them? And the relationships that are long-lasting and meaningful. When we get to this protocol development stage, I strongly believe stakeholders are important in this stage, but we also need to confirm the level of engagement we're speaking about here. Are we looking at, and if we look about level of engagement, Pollock's work on the active framework describes those levels of engagement extremely well. But we need to work out that protocol development stage is where stakeholders can help develop or approve the research questions that we should be looking at. They can even help with the search strategy itself, which is developed in the protocol development. Maybe any of those colloquial terms that you didn't think of, then they can. They can also review any protocol manuscript. When we moved on to the scoping review itself, well, they can take a very active role. And this can be from screening, selecting, and even extracting articles. Again, what is the agreed upon role that you've decided as a team? They can even check over results to see if they make sense. In the sense of a scoping review, it can be great when you've mapped all the available data to go, well, this is what's out there, but what is missing? And then having a team of stakeholders go, well, we're missing this and we're missing that, and that actually needs to be a focus. And they can also look at the implications of the findings to ensure that they are meaningful to the community. And remember, that community could be research community, or it could be those that have a lived experience. It's dependent on your research question. And after the scoping review, you could develop evidence summaries, or we can actually engage stakeholders as science communication strategies for social media, such as Facebook posts, Twitter. And we need to remember that stakeholders, alongside with researchers, and remembering those stakeholders could be other researchers, can really become great advocates for the findings of our scoping reviews and be able to spread the message of what we are finding. Now, there are further considerations that we don't necessarily have answers for. Firstly, we don't actually have any reporting guidance on how to report stakeholder engagement in scoping reviews. The PRISM SCR doesn't speak of this. And we need to also continually reflect on the work that we have done and evaluate stakeholder engagement in scoping reviews as well. And I just want to also highlight the issue of remuneration for stakeholders. Now, stakeholders may have an intrinsic desire to be involved, such as contributing to new knowledge, hearing what research is occurring, and really being part of the group. However, their time and knowledge to support the development and the conduct of a scoping review, their time should be appropriately recognised, and this can take in the form of compensation. You need to ask what they want and what they need, and that could be financial, it could be authorship, and it could be acknowledgement, or it could be all of that. But again, this needs to have clear and precise discussions with your team. So thank you. I just wanted to do a bit of a plug also to the scoping review network that we've got for JBI. You can QR code that and it will take you to our network page. Thank you.
Well done, very good plug. Thank you, Aili. Really important framework. We've got a comment from Karen in the chat who said really important first steps is confirming expectations and level of involvement. Do you want to just speak to that from your framework that you've, yep?
Just that I agree with that. I think having those initial discussions and asking how they want to be involved is very, very important. So we don't just presume. I think presuming can be the worst thing for any group work or any relationship. So having those honest discussions up front is very, very important. It goes with the pre-planning stage as well.
Excellent. Any other questions? Please type it into the chat. Question that I had while we wait, Danielle, is just whether you think that there's, for the different groups, obviously we've heard about consumers versus policymakers versus clinician researchers, so they're very unique stakeholders. Do you think that we need to tease out a little bit more about whether there's nuances with what you're proposing with those three subpopulations?
Potentially, I think the work we're doing, this is very much a starting point. So we're just giving basic principles that could be applied to all different types of stakeholders. But maybe in the future, when we look further into those relationships, we might see some more nuanced discussions about what they are and how to best go about those.
Excellent. Any other questions? No, you've wowed us all. Thank you, Danielle. That was a great presentation.
Thank you.
And our final speaker for the session this morning is Sally McDonald. So Sally is another dietitian. Well, we've got lots of great dietitians who's done a master's and PhD candidate at Sydney Uni. So she's going to talk to us about stakeholder perspectives in health claims. Fantastic. Over to you, Sally.
Great, thank you. So yes, I'm talking about my results from a qualitative study on the stakeholder perspectives on the use of systematic reviews to support health claims under standard 1.2.7 of the Food Standards Code. And I have no conflict of interest to declare. So health claims are voluntary statements about the relationship between a food and a health effect that's made by a food company on labels and in food marketing. So there's two types. We have general level health claims, which are about a food and its effect on health. For example, calcium for healthy bones or protein is necessary for tissue building and repair. So these claims can't refer to a serious disease. We then have high-level health claims, which are about a food and its relationship to a serious disease or biomarker of serious disease, such as diets high in calcium may reduce the risk of osteoporosis, or plant sterols clinically proven to lower cholesterol. So high-level health claims can only be used if they're based on a pre-approved list of claims. And I am looking at, in this study, general level health claims, which can either be pre-approved or food industry can actually self-substantiate a claim. So self-substantiation, so under current law in Australia, it requires food companies to produce a systematic review in order to self-substantiate or support a food health relationship for use on a health claim. So once the company has produced its systematic review, they then notify Food Standards Australia and New Zealand, or FSANZ, of their intent to use the claim. FSANZ then includes the claim on their website. So this is an example of what a food company will notify FSANZ of when they notify a claim. And so this is all of the information that's included on the website. So assessment of these, of the compliance of these health claims is undertaken by state authorities in the home state that the company is based in. And it's usually only done in response to a complaint about a claim. So if the claims are found to be non-compliant, it's the responsibility of the food company to actually remove the claim from the FSANZ website. There's no mechanism for state authorities to do this. So our objective was to capture the perspectives of stakeholder groups on the use of systematic reviews to support claims. So we recruited 14 participants from different stakeholder groups involved in the use of health claims. So 4 were from food industry, 2 from trade associations, and 2 were consultants. 5 from public health or academia. So these were researchers or public health groups identified as conducting research or advocacy on food labelling. And we've recruited 5 regulators from state and federal level. This is preliminary results, and we haven't recruited any consumer groups as of today. So I conducted semi-structured interviews, which were all conducted via Zoom due to health restrictions. And participants were asked questions on areas including their experiences with health claims, whether industry should be able to support or self-substantiate claims, and if systematic reviews were appropriate evidence. So data was transcribed and we conducted line-by-line coding to identify themes and concepts, and we then used inductive thematic analysis to examine relationships between themes and affiliations to offer an understanding of stakeholder perspectives. So this study has also received ethical approval from the University of Sydney. So on to our results. All of these quotes are using pseudonyms, so these aren't the actual names of any participants. So while all stakeholders had concerns about industry self-substantiation, systematic reviews were largely viewed as robust evidence and appropriate evidence by all stakeholders. They were reviewed as strong evidence of truth or validity for the claims, and that they helped companies feel confident that their products will actually have the effects that they're stating. We did have one industry stakeholder who viewed reviews as over the top or excessive for supporting health claims or setting the bar too high. Public health groups were particularly concerned and felt that industry shouldn't be the ones supporting or substantiating these claims that impact their profit, and that research conducted or funded by industry presented an inherent conflict of interest. Industry was concerned that the high resource burden to conduct systematic reviews would impede innovation, and they felt that it was not a level playing field for smaller companies with limited resources to fight for a market share and who may not have the skills or experiences to conduct a systematic review. And this was a concern that was also shared by some public health and regulatory stakeholders. Public health stakeholders and one regulator expressed concerns that claims that appeared dubious, such as multitudes of claims about collagen and cosmetic outcomes, were unlikely to be accurate or supported by evidence such as a systematic review. There is concern that companies may not be properly conducting systematic reviews or even at all in order to back up these dubious claims. One industry stakeholder also expressed concern that dubious claims would reduce trust in the industry overall. And although companies must provide the review to enforcing state authorities if it is requested, the systematic reviews are not made public, nor are they peer reviewed as a result of commercial and confidence laws. Public health stakeholders were concerned that this created a lack of transparency about the rigor or quality of these reviews, particularly for those supporting dubious claims. One industry stakeholder felt that companies with a good track record should receive more trust if their claims appear to be reasonably valid. So the use of systematic reviews sounded great in law, but the devil is in the detail and it's not really working. The operationalization of systematic reviews needs to be improved. Our food regulation should protect public health and enable informed decisions by consumers. And our findings so far suggest that while systematic reviews are appropriate evidence for examining the associations of foods with health outcomes, significant concerns exist with the standard among all stakeholder sectors. This is due to the risks of dubious claims, possible conflicts of interest, and limited transparency of systematic reviews used to substantiate claims, as well as the lack of peer review. Independent evaluation of systematic reviews before allowing claims on the market would address a number of these concerns. So thank you, and I'd just like to acknowledge that my PhD research is funded by a Countrywomen's Association of New South Wales scholarship. Thank you.
Thank you. What a fascinating piece of work. Questions, comments? Surely there's going to be some good discussion. Sam must have a comment, I'm sure. Yeah.
I just thought that was so interesting. I think, but a comment that did come, that has kind of come up, emerged in my mind, is systematic reviews, scoping reviews. Are we encroaching into guideline development? And it's really just a big thought. And I'm just kind of interested to hear from your perspective. And I know we're going to have a bit of a group discussion soon. We can throw that to the group in a minute.
Yeah. Well, I can speak more about so the development of this actual regulation. So Standard 127 allows health claims to be used that are pre-approved, which follows a more stringent structure that you would see in something like guideline development. From my perspective, it's about our concerns that you should be seeing a similar quality of evidence and rigor of evidence to support something like a health claim where industry is doing the work, as you would when you're seeing organisations like FSANS or NHMRC doing the work. You should expect it to be evidence-based.
Absolutely. So Elizabeth's got a question. I'll notice. Hand up, please.
Sorry, just unmute myself. Hi, thanks so much for that, Sally. That was really fascinating work, and I think it's such a fraught topic and so interesting. So thank you. I was just wondering whether anyone came up, because I'm aware that in New Zealand their process is a bit more like they have the actual checking of the reviews, I believe. Did that kind of come up in your discussion at all?
It has a bit. So I only gave a small sample of my results that focus more on systematic reviews, but in New Zealand we do see a different process. So in New Zealand they require, so it's done by the Ministry of Primary Industries there, and they actually require to review their dossiers of evidence, and they provide a lot more support to food industry in producing these dossiers, or a lot more advice than you see in the States in Australia, which is, it's partially due to their objectives. So for New Zealand, this standard is much more important because their food industry is much more important, or much more significant share of their economy. So they have a much more stringent process in that claims aren't notified on the FSANZ website in New Zealand without first actually going through that approval process. Whereas in Australia, it's only done after they're notified. So there is a difference, and in my perspective, New Zealand is doing it a lot better, but it's partially down to resourcing.
Yeah, that's great. Thank you very much. Thanks.
That's a great comment, though. Some of that's obviously historical, but surely how do we change the system? It seems from us, probably we're all evidence, synthesizers, guideline developers here. It's like ludicrous that but we shouldn't probably be too surprised. Where do you see the impetus of change occurring or needing to occur in this system if we move to a New Zealand type of model where there was greater assessment?
Yeah, well, the FSANZ, the Food Act is actually currently under review by FSANZ, and so one of the proposed sort of actions of that is to give FSANZ more of an enforcement power, but we're not sure that that's actually the ideal. So moving towards a model like New Zealand have would be definitely an improvement, but again that would require more resources provided to states. A lot of the stakeholders that I've interviewed just want this part of the standard scrapped. They even a number of food industry stakeholders were really not happy with it. It's really everyone had a lot of concerns about how it's conducted, and I mean industry want more of a self-regulatory sort of frame, which is obviously not what we want, but it's yeah, there's a lot of concerns about it among all stakeholders. So it's not there's no easy fix to it, unfortunately. Yeah. Yeah,
excellent. So Jennifer's also typed in a question on chat. How compares to health claims complementary medicines regulated by TGA?
Yeah.
Are you aware or know of that process?
I'm less aware of the TGA process, unfortunately. I'm not particularly familiar with it. I do know that for a lot of the claims that we're seeing notified, there's suspicion that companies are using the health claims notification process rather than going through TGA. So there's a lot of claims over the last 2 years that are on things that we would think of as more nutritional supplements. So things like these dietary collagen supplements that, there's tens of these claims about things that you would basically buy in a pharmacy, but instead of going through the TGA, they're going through FSANZ because it's an easier process with less oversight.
Interesting. And just maybe a final question. So when you talk about needing to do a systematic review, is there advice or guidance around what level of goes into that systematic review? Obviously, you can do a systematic review, but if you identify rubbish, very observational data, whatever your systematic review concludes is going to be less rigorous, obviously. Is there that level of guidance for the industry?
So they do, FSANZ has produced guidance documents, which is actually another part of my PhD was looking at these documents. And so they do detail the steps to conduct a systematic review, and Schedule 6, the food standards, also includes the sort of a checklist of requirements, which is things like having a PICO question and conducting a search using multiple databases. The actual requirements in Schedule 6 are pretty basic, but they do refer to other sources of information. They do refer to the Cochrane Handbook for one. So the issue is that the actual assessment of compliance is pretty basic on this, and it's not necessarily done by people who have that much experience with systematic reviews. So we're not, the instructions are there, but you still need to have some experience in order to follow them appropriately. And if you're a small company, you're not necessarily doing that.
Yeah. Well, thank you. That was really great way to end the session. I'd like to thank all of our presenters on a wonderful array of presentations. I think it's, for the whole conference being engaging evidence, to me, it certainly highlights that engaging in the right way, the right people for evidence synthesis and development in the first place goes a long way. But clearly we need to think about engagement and stakeholders, not just from the start, but right through into dissemination implementation. So some great examples there, some great food for thought. I wish everyone a great rest of the conference. Thank you very much for joining us, and we'll see you in the next session. Thanks very much to Sam too for co-hosting.
Thanks, Kelvin and all.
Okay, bye for now.
Thank you, everyone.